I want to invite Dr. Thomas Santarius and Tarek Ryan to moderate a session of Dr. Ed Benzel for tricks from masters. I think Tarek Ryan is with us. Tarek?
Dr. Zalili,
Yeah. Unfortunately, my internet connection is not good. But Tarek Ryan, you can moderate the session.
absolutely.
First, introduce Dr. Ed Benzel, and then start the session.
Yes. Good evening, everyone. It's quite not so late here in Abu Dhabi. I would like to introduce Dr. Benzel, Edward C. Benzel. Our prominent speaker tonight for this webinar. Dr. Edward C. Benzel is a distinguished neurosurgeon, the chairman of the Department of Neurosurgery at Cleveland Clinic and professor of surgery at Cleveland Clinic, Lerner College of Medicine, and Case Western Reserve University. So with no further ado, please, Dr. Benzel, would you like to start your presentation with us?
Hello, can you see my screen?
Yes, we do.
Okay, well, I'm going to begin with about a half hour to a 45-minute talk. I am going to go back and forth from lessons learned and teaching points to discussions of biomechanics, etc. So I'm trying to weave the talks in a way that I believe Dr. Zalali asked me to. Come on.
Can you make it a whole screen, please? Yeah, good. Thank you.
So my talk is Tricks of the Trade, and I'm going to call it My Journey. I'm assuming, and correct me if I'm wrong, that a large number of young neurosurgeons, including residents, are on this webinar. Is that correct?
Yes.
Okay.
Yes.
So I'm talking about my journey, and then what some suggestions of what your journey, the young neurosurgeons, might look like. I have 4 things listed here that were very impactful to me during my career. I was sort of a lost soul after medical school, and I ended up in a general surgery internship. And in December of 1975, I rotated on neurosurgery. And I was swept away. They offered me a job as a resident, and the rest is history. So my journey specifically began in December of 1975. Another seminal point in my career was during my first job at LSU Medical Center in Shreveport, Louisiana. This medical center did not have a neurosurgical residency. And I was the only neurosurgeon in a very busy trauma center for multiple years. And I established a clinical research team and a laboratory looking at ECIC bypass surgeries, etc., and published a lot of papers. And one of the basic scientists at the university said to me, and keep in mind, I was green, very young at this point, with little political experience. He said, I would like you to invite John Jane, an icon in the day of neurosurgery, to be our visiting professor. And I said, this is a daunting task, but I did. And he was evidently impressed and invited me to my first visiting professorship at the University of Virginia. Biomechanics has sort of become my trademark. And in the early 90s, my first spine fellow encouraged me to write a book because I had a lot of work that was just sitting around. And so I did. And I published this first Biomechanics of Stabilization edition, followed by 2 other editions. The second one had 32 chapters, and the last one had 40 chapters. And this has defined who I am from a clinical perspective. And more recently, Max Bowacki from Louisville in the United States crafted a question and answer book, which is listed, which is shown below, to answer questions regarding each chapter. Then I was encouraged by Micah Puzzo to make a volume for spine surgery like he did for brain surgery, techniques, complications, and avoidance and management. And I did. And now we're working on the 6th edition of this. Here you see the 5th edition. And in that, we discussed fundamental physics. Bending moment equals force times distance. A load F, or a force F applied at a distance d from an axis of rotation, causes a bending moment, which is the product of the force times the distance. This causes a concentration of stresses ventrally, which results in an angular fracture, in this case, a kyphotic fracture. Now, if that load is placed in line with the axis of rotation, we do not see a bending, nor do we see a concentration of stresses. Henceforth, it takes much more of a load to cause an injury. And of course, we can see other eccentric angles for fractures. And in this case, which is a chance fracture, the fulcrum or axis of rotation is in front of the spine in a seat belt without shoulder harness, deceleration injury in a motor vehicle accident. I said the last thing that is seminal here is the word pillars. Each of us who has met with success has probably had somebody else, perhaps in the background, that functions as their pillar. And this is mine, my spousal unit or wife of 47 years married. She has been an incredible support. So my recommendations to all of the young neurosurgeons who aspire to become an academician, get one of these. If you have one of these, a spousal unit, and she or he is a good one, then do whatever you can to keep her or him. And if you don't have one, find one. So this is my journey. I started off at Washington State University in 1967 after graduating from high school. And it's a small university in the state of Washington. And I got a degree in chemical engineering, but I found out soon that I really didn't like engineering, and I applied to medical school and was accepted at the Medical College of Wisconsin. in 1971. And I did my neurosurgery residency in 75 to 80. In those days, I think my class was the last of the 5-year residency. Then it went to 6, and then, of course, up to 7 in the United States. My first job was at Louisiana State University from 81 to 89. Did a lot of clinical care and research, as I've alluded to, and had John Jane as a visiting professor, which was another, as I already mentioned, seminal moment in my career. I then went in 89 for 10 years to the University of New Mexico. I had conflicts with a chairman of surgery. I was a division of surgery, so be careful of who your bosses are. But one thing I learned from conflicts is to always treat people the same. Everybody puts their pants on one leg at a time. If you're working with orthopedic surgeons or neurosurgeons, don't ever think you're better or lesser, because you need to maintain this egalitarian attitude. While at New Mexico, we started the American Association of Neurological Surgeons Spine's hands-on course. It was a week-long course, began in 1994 and continues today as the Cleveland Spine Review. It's over 30 years of continuous provision of education. I started a neurosurgery residency at the University of New Mexico, and I had some notable characters such as Mehmet Zalali and Dan Resnick, amongst others, who did observerships or rotations with me. They energized me, and I hope they got something out of their experience in New Mexico. I started a spine fellowship. I mentioned the first spine fellow recommended that I write a book, and I did, and also many manuscripts. Then I moved to Cleveland in 99 at the Cleveland Clinic. I became the program director and then the chairman, and now I'm an emeritus chairman and retired, I might add. I retired from clinical care, but still maintain my academic work, etc., at the Cleveland Clinic. I played a seminal role in the creation of the Center for Spine Health, which is a multi-dimensional, multi-specialty group, including orthopedic and neurosurgeons and physiatrists and pain management doctors. And each of us work in collaboration with the other and provide, I think, a much better service. There are obstacles. If you tangle with somebody, make sure it's somebody who you have rank over if you can, because rank usually wins. So I moved 3 times, which is what an average academic neurosurgeon does in the United States. But the last 2 moves were because I was up against people who had control over me, and in my opinion, did not have my best interests in mind. Take homes: focus on education. Don't give up. Follow your dreams. Resolve conflicts and be egalitarian, and strive to do the right thing. If you do those things, you will usually prevail. Now we're talking about your journey, not mine, but yours, whoever is listening here, I guess, to even the older neurosurgeons, but also in particular, the younger neurosurgeons. I define leadership, and you will see that leadership is an extremely important component of what I think is needed to become successful. The art of leadership is the art of causing others to deliberately create a result that otherwise would not have happened. If you go to the internet, you see all sorts of categorizations of leadership. Most of them are based on reward and punishment, except the last 2 here. Thought leaders are individuals who are recognized as an authority in a specialized field and whose expertise is sought and often rewarded. You want to be thought of as an expert, as a thought leader, as somebody who makes a difference. And then there's the servant leader, which I'm really pointing out to emphasize that this is a servant leader exists at multiple levels. Each of us are servant leaders because each of us are leaders. The servant leader serves the people he or she leads, which implies that those who are led are an end in and of themselves rather than a means to an institutional purpose or bottom line. Servant leaders lead people to a better place. The art of causing others to deliberately create a result that otherwise would not have happened. Theodore Roosevelt, a long past president of the United States, once said, "People ask the difference between a leader and a boss. The leader leads and the boss drives." And this cartoon, I think, depicts this very well. You want to be a leader, somebody who people want to follow. And as this chap up front here pulling the barge or whatever. Now, being a chairman of a department or some equivalent position requires this foundational servant leadership requirement, colleagues and healers effective and become an effective communicator. But they also need other skills, managerial skills, operational skills, and those three types of leadership basically, and including thought leadership, basically are what is necessary to lead a department, but not necessarily just leading people. Neurosurgery residents should lead each other. They should lead patients to make healthier choices. They should be functioning as a team and communicate effectively. For those of us who do not communicate effectively, and that's practically all of us, at least at some certain time, this book, Crucial Conversations, is a very good book that discusses how conversations can go bad and how they can go right and how you can make a conversation a win-win situation. Sometimes we get into conflict with another individual. And it's not because we don't care. Everybody wants to care. Everybody wants to have good relationships. But sometimes they go awry. What empathy is essentially is that it's the expression of the fact that you care. So constantly be thinking of caring, but also showing it, show others that you do care about them, about the topic at hand, etc. Leaders are competent. When we're interns or maybe medical students, we don't know much, and we don't know that we don't know much. So that's unconscious incompetence. When we become a first or second year resident, we become conscious of the fact that we're incompetent. And it's a very unnerving time for us. Then as we meander through the residency, we become consciously competent. We're always working at it, but by and large doing a very good job. And then we get complacent, take things for granted, and become unconsciously competent. But things can slip through the grates under this circumstance. So one of the things that we need to do is to reflect and have reflective competence. Leaders perpetually reflect. Here I will bring up a term heuristic, which is a rule of thumb. Before you conclude that these are two rules of thumbs. Before you conclude that a treatment was effective, look for other explanations. And if you see evidence of success, look for evidence of failure. Let's look at the first one. This is a large L4-5 herniated disc. And I could take this out and I'd get credit for a surgical save, if you will. The trouble is, for one reason or another, this patient's surgery was delayed and he got better. And we got another scan and showed that the disc was gone. Had I operated earlier, I would be taking credit for it, but that may or may not be appropriate. If you see evidence of success, look for evidence of failure. This lady had progressive myelopathy, did an operation, decompression, and a fusion. Looks pretty good. But let's look at her pre-op flexion extension x-rays and compare her extension x-ray with the sagittal alignment of the fusion. She had chronic neck pain because I put her in a position, an unnatural position of a straightened spine rather than a lordotic spine. And I keep bringing this case up over and over because it, to me, was an incredible lesson. So I'm just going to take us on a quick tour through my journey regarding cervical spondylosis, which is basically clinically manifest by myelopathy and deformity and radiculopathy. The myelopathy is a result of encroachment and tethering and repetitive trauma. Patients often will have a flexed forward spine and in the neck with an extension in the low back, which means they often have low back pain. And they also have the kyphosis trapezius sign. The trapezius muscle is a muscle of accessory muscle of extension, cervical extension, and is not really very effective. So if the patient can't extend their neck, then this muscle is often activated and becomes painful. This lady had an occiput to thoracic fusion for reasons that were not clear to me. It was done elsewhere. And here she is. Look, she's got the kyphosis trapezius sign. She's got an extended back, so she's got back pain. Look how far dorsal her plumb line drops from the L5, L4, 5 level. Here's another lady who had a compression and flexion fracture, osteoporotic fracture. And you can see how she's standing, got a sore back and significant kyphosis trapezius sign. So when operating on the cervical spine, focus on deformity. Why? You can diminish neck pain, improve myelopathy, decrease infusion degenerative changes, and improve short-term and long-term success. It is very difficult to correct deformities from a dorsal position, and I'll go over that. And oftentimes we need to correct from a ventral location at least, but it's all about leverage. We can use cast bar pins as a stands-like screw to correct the deformity. We can bring the bone to the implant by a 3-point bending strategy. You can see here a kyphosis is converted to a lordosis by simply engaging an intermediate point of fixation and moving it dorsally, as depicted here. We can use gravity. Viscoelasticity is the gradual deformation of a body with as a result of the application of a constant load. So this lady had multiple operations, had progressive cervical myelopathy and a lot of neck pain. She's got a fusion here and other joints are open. And she's got these signal changes in her spinal cord. But note, this patient was taken care of by me in the very early 2000s. And so I didn't have a full appreciation of this, but the bottom line is she has a signal change in her spinal cord in an area where there is both ventral and dorsal CSF densities. Well, we knew we could correct her ventrally because the facets weren't ankylosed. And we used a donut under her head, rolls under the shoulder, did some decompressions, then took the donut out and allowed her head to extend. You've got to be patient with this because viscoelasticity takes time to manifest itself, and ended up converting a 15-degree kyphosis to a 5-degree lordosis. It's all about leverage. But in the prone position, you have to focus on the head holder. And this, I quit too early. I wasn't persistent enough at trying to make sure that the deformity was corrected. The fixation follows as depicted. One could use a ventral and dorsal approach, but with this ventral approach, I lose the inability to use an intermediate point of fixation to bring the spine to the implant, and it requires two operations to operate a ventral approach and a dorsal approach. Again, this strategy is incredibly important for correcting cervical deformities. Lo and behold, her signal change disappeared. And here she is, pre-op on the left and post-op on the right. And so, in year 2000, I scratch my head and say, now we know, obviously, what's going on, but I didn't then. Here's another gentleman he's about 70 years old, who about 10 years prior had a laminectomy, and he got better, and now he's getting worse again, and this is his MRI scan. Remember that cervical spondylotic myelopathy is a manifestation of repetitive trauma and tethering and distraction. So this is him in extension on the left, and on the right, in flexion. This is what he looks like in flexion on an MRI scan. Significant stenosis, and basically these last two particular cases caused me to get flexion extension MRIs, which we now call dynamic MRIs, and we went through a rigorous process with our X-ray techs so that they would be well versed in dealing with this. And end the riff. If somebody has a myelopathy and you ask them to flex their spine, and by putting a pillow under their head, you could cause the myelopathy or the spinal cord compression to be worsened. And if the patient is in the scanner for a half hour, it could have very negative effects. So the technicians have to be very adept. We knew we could correct this because he moved at every level. His facet joints were jammed. They couldn't open completely. And so we did facet osteotomies as depicted here and corrected his deformity. And he did a lot better. But notice at C23, he is starting to bend forward. He's probably had too much stress placed on this, but we're going to learn in a bit that this angle, the C23 disc angle, is very important for minimizing complications. And today I would have zero hesitancy in going to the C2 because you lose so little movement, but you stabilize the spine so much better. Here's that C23 angle. He was repaired by his neurosurgeon in Puerto Rico, and even though he doesn't have great alignment, his symptoms abated. This is a 38-year-old male with a traumatic C7T1 disc herniation who underwent this operation at an outside hospital. And because he had symptoms, had the implant removed, and here he is. He was fused in this position. And so he's got back pain because he's trying to look forward and extending his low back. He's got the kyphosis trapezius sign. So we took him apart by doing multiple level facet osteotomies, and then multiple level, we used fibula allograft here, but you could use other spacers as well to bring the bone to the implant. So here he is now with the kyphosis trapezius sign gone. The C2-3 angle is important, and we did a study on this. When it's slanting down like this, there's a greater reoperation rate, a greater pseudoarthrosis rate, more chance for progressive kyphosis, and adjacent segment degeneration and disease. Also of importance is the C7T1 slope. It basically suggests problems in the upper thoracic spine that contribute to an overall sagittal vertical axis malalignment. You can see the patient has basically a cervical lordosis, or at least a straightened spine, but his head is way ahead of his upper thoracic spine. We use a C2-3 angle for intraoperative utility. This is a patient who has a lot of axial neck pain and myelopathy. We knew we were really going to have trouble changing the angles of these upper cervical or mid-cervical screws. So we did a C7, T1, T1, T2, T2, T3 facetectomies, and corrected the deformity down below, and then ended up looking like this intraoperatively. And we said, well, if we take that left x-ray, which is an intraoperative x-ray, and we flip it 90 degrees, this is what it's going to look like. And it looks pretty much like the C2-3 angle is horizontal to the floor, as depicted in this middle illustration and the one on the right, if the patient were to be standing. So I'm going to show this one more case here because I think it's important. It's a 34-year-old male, so he's young and mobile, and he's got a small fiber neuropathy, which has contributed to a spinal deformity that you see here. He is absolutely miserable. He's got a mild radiculopathy because of some degenerative changes. And here's what he looks like in his scoliosis x-ray. And you may note that I get a lot of scoliosis full-length x-rays in order to fully assess the spine, because taking just the cervical spine alone is in isolation can lead to unexpected and untoward consequences lower in the spine. So we did a C4 and upper C5 laminectomy to decompress, a C4-5 bilateral foraminotomies, and a C2-5 instrumented fusion. Multiple partners told me you're not going to be able to get this corrected without going farther down into past the cervical thoracic junction. And I said, there's one thing that's different about this particular patient and the rest of the population that we operated on, and that is that he is young. His spine is mobile. So I put in the screws and then contoured the rods and basically pushed down in the middle as I locked the screws to the rods, and was able to have a shorter segment cervical sagittal alignment and a lordosis, retained lordosis, as you can see here. Here he is pre-op and here he is post-op. And you can see that if he had scoliosis, the scoliosis views helped a lot. And as his spine is realigned, his plumb line changes. This is because he's not, within the picture on the left, which is pre-op, he's leaning backwards to see forwards. Okay. Now he no longer does that. So this plumb line moves forward because he doesn't have to lean backwards. Well, if you look at the literature, it is abundant regarding the suggestion that abnormal angles at disc interspaces causes accelerated degenerative changes. And so we used the C2-3 angle intraoperatively to tell us when it was time to stop. But equally important is if not more important because of the volume of patients, is the short segment fusion that we do like with an ACDF. We should never settle for having a patient left with a kyphotic deformity like this, because they almost assuredly will stress adjacent segments out and have adjacent segment disease. If we maintain lordosis, the chance of that happening is small. So I beg of you to look past the images, look at the human being in whom the spine exists with its pathologies, understand the patient's feelings and expectations, and make sure they're aligned with yours. You don't want them to be, the patient to be thinking cure and you saying, maybe not. They need to be completely in line with you. We all need to be socially aware. In other words, be empathic. We all need to have goals, or a vision and goals. We need to have self-direction. We need to be able to make decisions and problem solve. We need to motivate the patient, colleagues, and others to function as a unit. And we need to be self-aware. And I already listed with the competence discussion that the ultimate form of competence is reflective competence. We must always reflect. How am I coming across? What is the patient telling me? And listening is probably an art that is underutilized in modern medicine. And listen reflectively. So, leaders inspire. This was my leader, my chairman of neurosurgery, Sanford Larson. He didn't write this line, and I don't know where I got it, but it describes him perfectly. He was basically a lousy lecturer, but he led by example. People wanted to be, his residents wanted to be like him and do the right thing. And that is what I'm asking of you all. We are all leaders. We get patients to better places. We cause them to take their medications and do exercises and diet if we can. We work with colleagues, friends, and family to build something together, to solve a problem together, to respect each other, to trust each other, and to have mutual respect for each other. So my message to you, and myself, every single one of us, is to lead. Because at the end of the day, if you have been successful in these things, when you go home, you're going to feel like clicking your heels. I thank you very much. I'm having trouble getting back to my regular screen.